So thank you so much, Steve. We're happy to be back presenting at the ICOS seminar. And actually, Dr. Daniel Addison, who's one of the co-directors of our cardio-oncology program, is going to begin.
Good morning, and thank you all again for joining us. And we're a little biased, as Steve said, but welcome to the SHU, or at least, as we like to say, welcome to the Ohio State and what we're trying to do with cardio-oncology. Here's a brief listing of our disclosures, and we're here to now talk today about TKI-induced, or a brief listing of our disclosures. Yes, NIH, AHA, and others. So again, our talk today is entitled TKI-induced cardiotoxicity in hematologic malignancy patients, the impact of novel FLT3 inhibitors. And again, today's presenters will include myself, Dr. Courtney Campbell, and Dr. Lisa Kim, all of which are committed to the pathway of cardio-oncology and very much thrive interested. Next slide. So again, here's a disclosure. All right. Here, I'll go ahead and let the good Dr. Kim proceed with our case.
Okay, so to get started, here we describe a 56-year-old woman with acute myeloid leukemia diagnosed 2 years ago. She was in complete remission after 7+3 induction chemotherapy with cytarabine and daunorubicin, followed by maintenance therapy with azacitidine, which was stopped about 10 months prior. She was not deemed a stem cell transplant candidate at that time, given a lack of caregiver options. And then about a year later, she presented to the emergency department with recurrent fevers up to 102 degrees Fahrenheit, fatigue, myalgia, diffuse ecchymosis. She is found to have new leukocytosis to 53 with 86% blast, acute anemia to 7.6, and new thrombocytopenia to 18, which is highly concerning for AML relapse. And thus she was transferred to our institution for management. Her past medical history is significant for hyperlipidemia. She also has osteoarthritis, anxiety, and GERD. She's a remote smoker. She quit back in 2000, no alcohol or illicit drug use. And her family history is notable for lung cancer in her father and paternal uncle. She takes minimal medications at home, just meloxicam, omeprazole, and Zofran as needed, and she's allergic to statins with reported anaphylaxis, as well as penicillins, which caused hives. She was admitted to our hospital for febrile neutropenia and concerns for relapsed AML. She was immediately started on empiric antibiotics, and a broad and immunocompromised infectious workup was performed, including extensive testing for viral, bacterial, and fungal pathogens, which were all negative, including for COVID-19. She underwent a CT chest, which showed patchy opacities in her lower lungs, and then eventually a bronchoscopy was performed, where she was subsequently diagnosed with Serratia marcescens pneumonia, and she completed the appropriate antibiotic course for this. For her relapsed AML, a peripheral blood sample was obtained for mutational analysis, and it showed new FLT3 internal tandem duplications as a promising therapeutic target. So prior to initiating targeted therapy, she underwent baseline cardiac testing. This was her baseline electrocardiogram, which was normal without any evidence of ischemia, just some T-wave inversions in V1 through V3. And then this is her baseline echocardiogram. I'll let Dr. Addison give his visual interpretation.
Thank you again, Dr. Kim, and outstanding job thus far by our esteemed resident. As many of you can see from both the peristernal long axis view in the upper panel, as well as the apical four-chamber view in the lower panel, LVEF appears to be preserved. And overall, this appears to be a generally otherwise unremarkable echo. RV function also appears preserved.
Oh, it's a little slow.
So for her AML treatment, she underwent cytoreductive therapy with hydroxyurea and then started monotherapy with gilteritinib, which is a novel tyrosine kinase inhibitor. It specifically targets the FLT3 ITD receptor, and she received a total of 4 oral doses every 24 hours before she acutely developed worsening shortness of breath, orthopnea, and leg swelling. She was afebrile. Her vital signs were stable. She was satting well on room air. Her physical exam was notable for mild bronchi and slightly diminished breath sounds at the bilateral bases. She had jugular venous distension, regular rate and rhythm, as well as 2+ pitting edema of her lower extremities. Her labs were notable for an abnormal CBC, but stable from previously, as well as normal chemistries. Her BNP was elevated to 1,574 from 195 on admission. And then her troponin was mildly elevated to 0.36 from less than 0.11. A repeat chest radiograph was obtained, which revealed new cardiomegaly on the right side, and then worsening bilateral airspace disease compared to admission. And then a repeat electrocardiogram again was obtained, which did not show any evidence of ischemic changes. It was similar to her baseline. And this was her repeat echo post-gilteritinib, and I'll let Dr. Addison comment on the images.
Thank you. So, again, in the same views or the same panels, again, parasternal long axis and the apical 4, we can see as compared to before, although the clip is a little bit slow, LV function appears to be at least mildly depressed, likely somewhere in the area of roughly 40%, just visually looking at it. The LV cavity as well also appears to be more dilated or at least enlarged as compared to before.
The final read on the echo showed a newly reduced ejection fraction to 35 to 40% compared to 67% from 5 days prior. And it also showed focal septal hypokinesis, new moderate to severe tricuspid regurg, and an elevated right ventricular systolic pressure to 50 millimeters. So during her hospitalization, gilteritinib was promptly discontinued due to concerns for acute cardiotoxicity. She eventually developed acute hypoxic respiratory failure requiring up to 8 liters of supplemental oxygen. She underwent IV diuresis and was eventually started on heart failure guideline-directed medical therapy with metoprolol XL, lisinopril, and spironolactone. She was deemed too high risk for cardiac catheterization given her AML. So instead, a cardiac MRI was obtained 2 days after discontinuing gilteritinib. And this was the read on her cardiac MRI. It showed borderline biventricular function with interval improvement in her ejection fraction to 51%. Late gadolinium enhancement imaging revealed patchy mid-wall fibrosis in the septum and lateral walls. And there was also an elevated T2 signal in the inferior septum, suggestive of myocardial edema or inflammation, findings consistent with an inflammatory cardiomyopathy. I'll let Dr. Addison comment on her cardiac MRI.
Okay, so I think many of us have already got at least a little bit of the answer, but importantly, again, here we can at least demonstrate that the LV cavity appears to be relatively generous, at least borderline mildly dilated. Overall systolic function appears, at least visually, to be somewhere in the neighborhood of 50%, kind of borderline mildly depressed, low normal. There is at least a trace to small circumferential pericardial effusion. There's not really significant pleural effusion, although maybe you can argue a trace pleural effusion on the left. Otherwise, the atria appear of relatively normal size. And here we can see our T2 maps, and importantly, just to kind of maybe oversimplify things, the main take-home point here is when you see uniformity in the color scheme, it's often relatively normal when it's darker. In this case, in the septum, that is where the red arrows are located, you can see a relative brightening, that is relatively lighter color as compared to the surrounding tissue or myocardium. Here it just so happened, as we listed here, the T2 signal actually read out as max of 70 milliseconds, with normal being less than 53 on this magnet. Although not shown here, the T1 maps as listed here did reveal elevated native T1 and elevated myocardial ECV as well, extracellular volume fraction, which is generally a sign of diffuse fibrosis and / or interstitial edema. Next slide. And here in the lower panels, we see the LGE imaging. And again, this is at the level of the mid-ventricle. And importantly, in the septum, we can see at least some element of mid-wall fibrosis. It looks to be relatively patchy in nature, but at least there. And there are a couple of foci, particularly on the left-hand panel, again, in the actual mid-septum, both extending from the anterior septum into the inferior septum as well, relatively close to the same regions that we have seen the elevation in T2 signal. Next slide.
So after her acute issues were addressed, she was discharged from the hospital and the patient followed up in our cardio-oncology clinic. Follow-up cardiac studies were obtained, including an interval echo at 3 months, which showed improvement in her ejection fraction to 45 to 50%. And then another echo was obtained at 5 months, which showed continued improvement to 50 to 55% with global longitudinal strain at negative 17.6%. She also got a repeat cardiac MRI about 5 months later, which showed mild non-ischemic fibrosis and importantly showed resolution of myocardial edema and inflammation on T2 mapping compared to prior. And then I'll let Dr. Addison provide his interpretation of her follow-up imaging.
Okay. And again, thank you. So as we see, the loop is a little bit jumpy, but importantly, you can better ascertain that it appears that the LV cavity at least appears a little bit less generous or potentially smaller, and also appears that squeeze or basically systolic function is a little bit more vigorous here. I would put this at least in the low normal to closer to 55% range, just visually looking at this echo. I'm not completely certain if this was the 3-month or the 5-month echo, but either way, the LV function appears normal.
It's the 5-month echo.
Okay. Thank you, Dr. Campbell. All right, so, in hospital, as you can see, these are the same images that we alluded to before. The right-hand panel, I think maybe the titles got a little bit switched, but importantly on the left-hand side, the SSFP-based imaging, that's the cine imaging. That's where we described the LVEF to be somewhere in the neighborhood of 50. The middle panel, the T2 map, shows again the elevated signal, and then the right-hand panel, LGE, also shows some element of gadolinium uptake, again suggestive of at least some element of patchy fibrosis there. And 5 months later, we see now, as you can see on the right-hand side, although we don't have cine actual imaging in terms of playing, we can at least see that, the cavity looks relatively similar, but, I've been briefed on the reports, less seeing the images to know that it's now reached at least a steady low normal or 50 to 51 to 53% range. Importantly, again, the middle panel does show, again, color uniformity, which again suggests relative resolution of the actual focal/regional edema that was seen on the initial T2 maps. And then importantly as well, on the right-hand panel, the actual areas of fibrosis are much less prominent / potentially even absent, at least on this visual assessment from the mid and short out.
So in summary, this patient's non-ischemic cardiomyopathy improved with recovery of her ejection fraction to 50 to 55%. She continued losartan 50 milligrams twice daily and carvedilol 25 milligrams twice daily. And then for her AML, the patient declined to ever be rechallenged with gilteritinib monotherapy. She went on to receive 2 cycles of azacitidine and venetoclax before achieving morphologic and molecular remission of her AML. And then 6 months later, she received an allogeneic stem cell transplant from a matched unrelated donor.
All right, so that draws our case to a close. Anyone have any comments before we get into the discussion?
So could you describe, this is Dan, the other one, the could you describe the sort of time course of what happened at the beginning? Because uh, you know, you're painting the story that this is related to the gilterid, the the G medication. Uh, but also, I mean, what else could explain those findings that you reported on the MRI, for example?
So in brief, the timeline is she presented to the hospital. They thought it was AML and did the molecular diagnosis, and more or less the next day started the gilteritinib. And 4 days after starting that medication, because it's dosed every day, she developed heart failure, and it was stopped that day. And then we got the echo images confirming the heart failure, and then 2 days after that, we got the MRI. So that's kind of the timeline. And then about 6 months before we got the follow-up MRI.
Yeah, so for example, the ECV that was elevated in, you know, in the initial image, which went down later on, you know, ECV in most situations, if you're suspicious, as you guys surely know, if you're suspicious of amyloidosis, for example, the ECV is a fairly specific finding for, you know, evidence of fibrosis, perhaps related to amyloidosis, especially if it gets significantly elevated. But could leukemic infiltrate do the same thing?
That's a great question. And really, I think, to your point, and excellent points, Dan, the other two big differentials, as Dr. Campbell was alluding to, really include, again, the leukemic infiltration, but also even a transient myocarditis. When you see this sort of kind of borderline mild elevation ECV with some level of infusion and then also some regional edema. Now, she didn't have any clear sequelae to support a myocarditis. There always could have been potentially a leukemic infiltration. It's very hard to know that without doing an actual formal biopsy. But the regionality, or at least the focal element or relative regionality, and then also the patchy nature of the LGE. So often we don't really see a lot of LGE leukemic infiltration, or at least tumor infiltration. It can be there, but you know, that's not necessarily a purely classic finding. And so, you know, initially the confluence of findings and the timing generally pointed in this direction.
And I think something that should be differential would be something like a Takotsubo, just with the acute stress, but with I think the MRI imaging in particular, and you know, just looking at the pattern of her, like with a global hypokinesis, that it didn't really fit that picture.
I guess the other question, this is always sort of our own personal challenge, is that you have these beautiful images and they're all lined up perfectly and everything looks really nice. But just like if we order an echo, they don't typically do strain in every echo that we ask for it. And in an MRI, they very rarely do ECV, and I'm not really sure that they typically or always do T1 or T2 mapping. So is that an ongoing issue, or is that something that you guys have managed at Ohio State, or what do you think about that?
I'll speak from the strain standpoint when we were going through this case, because we didn't meet her till after her hospitalization, but there actually was strain on the first echo. It was minus 21%, and that is something we are doing almost very routinely for pre-chemotherapy echocardiograms. There wasn't strain on the one on the echo with the acute heart failure. But we did get it on, you know, the 5 months later before they were going to do the stem cell transplant, and it was minus 17. So it's definitely not consistent, but especially when there's something cancer related in the order, it's something that our sonographers are getting on a fairly routine basis now.
And I will also add on, go ahead.
I was just going to let Dr. Addison talk more about our MRI protocols.
The beauty of virtual patients. So for the MRI imaging, we are getting mapping relatively standard here at our center. For a long time, we had focused a lot in T2 mapping as well as in T1 mapping. So we have worked diligently within our, our purviews of cardio-oncology to make it relatively common or standard that most of our cancer patients are getting some form of mapping at the time of actual imaging. And if there's any suspicion, to certainly add T2 mapping to make sure that we at least have that information available to us, just so that we have at least the most complete picture of the patient's going to get scanned.
Guys, it's Joe Barber. I'm like scratching my head because I've seen lots and lots of gilteritinib patients and never saw this. So I'm hoping in your discussion you're going to educate us. Either temporally it's there. I just haven't seen it. Which doesn't mean it doesn't exist, but.
Thank you. And I think here is where we'll let the good Dr. Campbell go ahead with her slides and the discussion about the FLT3.
All right. So just because I know a lot of cardiologists are in the audience, and in part for my own review, so AML is acute myeloid leukemia. It's coming from the myeloid stem cell line of the hematopoietic lineage. And when you look at the bone marrow, the top is healthy bone marrow with a wide variety of different white blood cell types. And then you see the AML bone marrow, which is dominated by the myeloblast. And so this is the key way that they're diagnosing it, in addition to looking at the peripheral blood and seeing a high number of blasts. So FLT3 is FMS-like tyrosine kinase 3. It's expressed when they were developing the drug, they thought almost exclusively in the hematopoietic cell type. And constitutive activation occurs in about 30% of AMLs. And it's associated with a much more aggressive disease course and a higher rate of relapse. So there's two FLT3 inhibitors that are used for relapse to refractory AML, and those are gilteritinib as well as midostaurin. So to the right is just a diagram of some of the pathways that the FLT3 tyrosine kinase activates, and you see that there's multiple different, from the JAK2 to the RAF-MEK, ERK, pathways that ultimately lead to cell survival and proliferation when it comes to a myeloid stem cell. So lots of different pathways that it's acting on to get there. So to look more specifically at the FL3 inhibitors, so like Lisa said, there's these internal tandem duplications, which is, you see on this, an active conformation, and and then there's also the TKD mutation, which is for constitutive activation, indicated with the star on the active conformation. So you'll notice probably some familiar names in the FLT3 inhibitors. So both midostaurin and the gilteritinib are type 1 inhibitors, which will inhibit both the ITD and the TKD mutations. Same with sutinib, as well as ponatinib is just for the ITD mutation. So all of this kind of underscores, when we're thinking about tyrosine kinase, that they are very promiscuous. They all have primary targets that we tend to use them for, that our oncologist colleagues use for in cancer. However, they're promiscuous and they're affecting many different TKIs. So this is just an example of some of the therapies that are used, their primary targets, and the risks that we have observed with these. So with the HER2 inhibitors, like trastuzumab, there's a cardiomyopathy associated. With the VEGF inhibitors, hypertension is the most common cardiovascular risk that we're seeing. With the BCR-ABL kinase inhibitors, we see a lot of venous thromboembolism in specific types, as well as ischemic heart disease. And then the BTK, like ibrutinib, tyrosine kinase inhibitors, atrial fibrillation, and hypertension are some of the most common. But when you think of any TKI, the plethora of potential targets is important when you're thinking about cardiovascular toxicity. So this is just one example from a old but great review article from Tom Forrest that was published in Nature about 15 years ago now. And it just shows sunitinib, which also is a FLT3 kinase inhibitor, and how it's acting on different pathways within a cardiomyocyte. So you see with the mTOR and AMPK, the bad Bax pathway, and the various ways it can lead to cardiovascular toxicity, from hypertension to myocyte loss and LV dysfunction. And then the very things we're looking for a cancer, like capsase activity leading to apoptosis to kill those cancer cells, those same pathways can be activated in a cardiomyocyte. So that's a potential important way that we're getting this cardiotoxicity, is that the targets for the oncology drugs, these TKIs, are not exclusive to the cancers themselves. So for gilteritinib, it's a dual TKI, both for the FLT3 and the AXL. I'm going to focus on the FLT3 since that is the focus that's the primary target that they're using. But there is quite a bit of research on the AXL pathway, and inhibition might potentially be cardioprotective, but that's much more in depth than I'm going to go. But so gilteritinib was approved after the Admiral trial was published in NEJM back in 2018, and it's approved for monotherapy, like we said, for relapsed or refractory AML. And they studied 371 patients, the majority of which got this oral gilteritinib drug, and compared it to salvage chemotherapy. So the median overall survival improved to 9.3 months from 5.6, and then complete remission with full or partial recovery was 34% versus 15%, so almost doubling what would be expected from the salvage chemotherapy. And they promoted that there was lower incidence of adverse events with the gilteritinib, so generally it was pretty well tolerated. And something just to emphasize when it comes to AML, you notice we mentioned a few times the stem cell transplant. So a lot of the goal of the chemotherapy is to get the AML under control to the point that you can then perform a stem cell transplant, which would be more curative than staying on chemotherapy. So the point is to buy time in order for the patient to undergo the transplant. So for the cardiotoxicity, as it's known in cancer trials, so for this particular trial looking at the 247 patients that received the drug, they looked at adverse events only within the first 30 days after the last dose. And as I said, this is a drug that's dosed daily. So they did notice QT prolongation in 7%. That was the most common. Heart failure was found in 4%, pericardial effusion in 4%, and then pericarditis and myocarditis. And just to compare to the related midostaurin, they didn't publish the time frame that the adverse events were when they were collecting that data based on the clinicaltrials.gov database, but they did see a large number of QT prolongation, similar, a small percentage of the cardiac failure, and then infarction or ischemia. So these are, while they're rare, were recognized in the trial, but certainly not something that was really discussed in the published papers. So actually, just Dr. Addison, did you want to comment any further on the cardiotoxicity in the cancer trials here?
No, thank you. Again, I think the important note here is that essentially in the control arms, there was essentially no events reported for both therapies, particularly gilteritinib, which is very interesting considering, again, they only followed the patients for the first 30 days and looked at them with, non-cardiologists who were adjudicating events and so forth. And these are the values that they saw. I'll also make at least one other comment, I think, about the case, but again, we'll come back to that a little bit more. And I think the critical element, and one point that I think Dan raised, is really whether or not we would think that this is actually leukemic infiltration versus actual drug-induced. So when she came in, she did not have heart failure. She had no clinical sequelae or evidence of heart failure. Now, the imaging was obtained, repeat imaging, after she developed the symptoms, but nevertheless, she had symptoms roughly about 4 days after initiating therapy. And so really thinking about the time course and also thinking more so about the review, at least of the available clinical evidence, particularly with these clinical trial data, led us to generally, along with the MRI findings, think or suggest that there is the potential that this drug actually may have precipitated her clinical manifestation. It is true, though, it's difficult without a biopsy to exclude leukemic infiltration. But again, the clinical context and the patient just felt strongly that she didn't want to even take that chance.
And then I think your hands are tied a lot of times in these leukemia patients because they have pancytopenia that's expected to last through a lot of the treatment. And so doing any kind of intervention or invasive procedure risk definitely outweighs the benefit with, platelet counts in the teens or, I think at one point hers was 6. So doing something more conservative like a cardiac MRI is probably the most comprehensive we can be in that scenario of acute therapy. So
maybe one other last thing. I'm sorry, Courtney. So often this is the common scenario that we all face, I think, worldwide. It varies according to center, but often you're asked to give thoughts on a patient, maybe who is, seen by colleagues or others or something else, and really at the end of the day, you're trying to give the best judgment. And often we're tasked with just basically trying to understand if there's the potential of the drug or the potential of something else that may be relating to what's going on. And so thus, this is, I think, a very interesting clinical presentation to at least think about whether there is any relationship here. Mm-hmm. Please, Dr. Campbell, go forward.
All right, so for what we know about the FLT3 in the heart, so like I said, if you look up all the reviews about these inhibitors, they talk about it being almost exclusively expressed in the hematopoietic cell lines. However, a nice JACC paper from 2014 did show that FLT3 and its ligand, both the mRNA and the protein levels, are expressed in cardiomyocytes. So some of the data they had before was from whole hearts, which you can imagine would include some blood, but these are from isolated cardiomyocytes that did show that FLT3 was present and active there. So there's only really one paper that explores its role in the heart from Pfister. So there was notice that the gene expression of both the FLT3 and the ligand were increased after myocardial infarction. So they developed, their hypothesis was that it plays some role in ischemic myocardium. So the test that they did, or the experiment, was they took 30 mice. They did an LAD ligation versus a sham operation. So where they're opening up the mouse chest and just literally using a suture to tie off the LAD to give a myocardial infarction. And then they, right afterwards, injected the mice, half of each arm, with the FLT3 ligand or a vehicle. So this would be activating the FLT3 pathway, doing the exact opposite of the chemotherapies. And then after only a week, they evaluated the results in the mice. So this first panel here is showing that the ligand, so activation of this pathway, decreased the infarct size. So you see a cross section here of the LV and the right ventricle, and you can see a very large myocardial infarction in the one labeled MIV. So that's the mice that received vehicle. And the mice that received the ligand, you see a much smaller scar pattern. And then they quantified the infarct size in panel B, showing from a 40% down to a 30%, and that was statistically significant. The next thing they looked at was apoptosis. So panel C is just an example of how they tested this. So the nuclei are stained blue. Actinin is in the myocyte, so you see those in the stripy red stain. And then tunnel, which is the white stain, is indicative of an apoptotic nuclei, so a cell that has died. And in the mice that received the FLT3 ligand, there was a decreased number of the apoptotic nuclei of the cells that died. So you see that quantified in panel D, showing a decrease in the percentage of tunnel positive nuclei, and that was statistically significant. And then the last thing they looked at is remodeling. So they did echocardiogram, but actually they just measured the total wall thickness change at 1 week. And this is a delta compared to the baseline before they did the infarction. So you see the wall thickness changed negatively, so kind of thinning out with that scarred myocardium in the vehicle treated, and then similar to baseline in those that were treated with the ligand. So overall, they're showing that the ligand or activation of this pathway decreases the infarct, stops apoptosis, and improves remodeling. So you can imagine that if this pathway is blocked, like in the cases where we're using these inhibitors, that the heart would have much less reserve potentially to respond to insults and the ability to respond to something like a myocardial infarction. That said, there are no studies that look at what the blocking this pathway does to the heart. This is the only one that really looks at what it does activated in the heart, but does show that it does have an effect in the heart, and that FLT3 itself is not limited just to the hematopoietic stem cell line. So just that kind of wraps up the discussion and what we know about FLT3. And I think our case is showing that early cardiotoxicity, even within the first few doses, could be associated with gilteritinib. I don't think we have a great alternative theory in our particular case. And it's a non-ischemic and a myocarditis is what we showed. And then that this was reversible when we removed it. So the patient did recover, although not completely back to baseline because her ejection fraction was in the 60s before she started this therapy. And whether or not it occurs with rechallenge is unknown. The patient, regardless of what we think if it's related, the patient firmly believed that it was related and did not want to try that drug again. But I think it also emphasizes that cardiac MRI can be really important in helping, kind of differentiate or try to diagnose the cardiotoxicity that we may or may not be seeing in patients that are receiving this targeted therapy. Dan, any other thoughts? Addison?
No, thanks.
No, I mean, I think this is interesting, and I hadn't really explored the mechanistic, studies that have been done on inhibiting FLT3. I guess the real question is from a leukemia point of view, how important would it be to convince that patient to retry the drug, or just say that because of intolerance that you go to a different therapy? I mean, how strongly does gilteritinib add to the treatment picture for leukemia? So making an analogous argument, in the case of trastuzumab, if you saw transient LV dysfunction with trastuzumab and you said, well, I can manage this LV dysfunction with heart failure medicines, and when patients stabilized, we can restart trastuzumab because it's so important. And that's in fact basically what we do. But how important is gilteritinib in the whole picture as far as leukemia treatment?
Yeah. Go ahead, Dr.
That's a great question. So, we had several conversations again after her discharge when she followed up with us with her AML team and her AML doctors, and particularly the transplant team as well. So there were other potential kind of second line therapies for which she could potentially at least be engaged in or treated, in which she did try, including venetoclax, et cetera, to see if potential molecular remission could be achieved. The key goal with her was really to get her to a point, as Courtney said, to really where she could be transplanted to attain more long-term remission of her disease. And so their thought or their thinking was essentially to try at least previously available therapies, given the potential that glucarinib could have played some role in her picture, to better understand whether or not she could actually get to remission. And if she failed that, then we would potentially cross that bridge. And in that case, I think that's where really, in addition, MRI starts to become very interesting because, at that point, if she's recovered and her T2 looks like it's normalized, and then you re-challenge the patient, MR conceptually could be used as a marker to better understand her response over time, particularly with the parametric mapping to be able to see subtle changes even before decrement in LVEF. Of course, we can get strain with MRI, get a lot of things. But in her case, thankfully, she was able to get to remission even with venetoclax and so forth, and thus she did not necessarily need to be re-challenged. She was able to get to stem cell transplantation. I think lastly, again, we emphasize that in conversation with a lot of our hematologists, the biggest thing that they really look for in a lot of these AML patients is to be able to get them to the point that they can be transplanted. And, the whole slew of potentially of novel targeted therapies often really just prolong kind of the time frame. I think about it almost in conversation, I think almost like an LVAD. So we're basically trying to bridge them to the kind of final destination therapy, being in this case, transplant. And so really that was her situation. Courtney.
Yeah, I agree with everything Dr. Addison said. I think we were, fortunate that with this patient, we didn't have to cross the bridge of whether or not we really needed to re-challenge. She did respond to some of the medications she'd actually been on previously, and we were able to avoid that. But it is a very interesting question. And, it's an N of 1 case on, if we would see this again or if something else was going on. From that standpoint. And then kind of one last thing I wanted to, draw everyone's, attention to, remind you, and like the bigger discussion of the underreporting of cardiovascular toxicities in cancer trials. So, when these drugs are approved, cardiotoxicity really is kind of mentioned in passing in like the NEJM paper or, something like a small percentage of QT prolongation, but it's never something very severe. So, it's not until we really are seeing these in real world clinical practice and giving these drugs to a much larger than 200 patient clinical trial that we're seeing some of these cardiotoxic events. And so one example here is looking at the, ibrutinib, where there was an increase in unexplained deaths. And you can also see that, this is from Dr. Addison's JACC paper from last year, that the expected anticipated risk of CVD incidence is significantly less than what you see in non-cancer trials. So, the cardiac endpoints are not being adjudicated in almost every situation by a cardiologist. So whether or not these events are happening or being recorded or being linked to being related to the drug, regardless, it's underreported. So I think a lot of us find ourselves in these situations where really an unanticipated potential cardiotoxicity of these drugs. And this is an example of one that we had and how we ended up managing it and trying to work through the potential relationship.
Courtney, looks like there are a couple questions.
Oh, great.
Sri, do you want to?
Yeah. Hi, Courtney. This is Shri, Cardio-Oncology fellow. I just had 3 quick questions. Number 1, I missed a few parts at the beginning, but were biomarkers checked and were they elevated? And then the second 2 questions pertinent to the MRI. If she wasn't, because she came in with some fever, so like if she was in some sort of inflammatory state, that could have caused the T2 elevation. And then how do you explain that LG did not persist and just resolved in 5 months, because it's a marker of fibrosis, and I would think maybe it would persist a little longer. So those were the questions I had.
Courtney, I'm not sure you could hear that.
I had a tough time understanding it. I think at least one question was about the inflammation and if something else could be causing it in the on the CMR imaging. And then I believe the second question was about why there wasn't a persistence of the LGE and how we potentially explain that. Is that generally at least the last two parts of your question?
Yeah, I think you'll have to do your best on that.
Okay. Well, Dr. Addison, do you want to speak to those points since they are cardiac MRI related?
Absolutely, and I think we'll do our best to address that, and hopefully it'll answer the question. I think I also heard something about biomarkers, so just the confluence of I think those questions and really the findings. So when you see kind of relatively more regional edema, you really have to think about inflammatory processes like either sarcoid, myocarditis, or some other potential inciting inflammatory event. In this case, there was some general borderline elevation even outside of the actual septum. We didn't show the measures there. Overall, I think the key things that you think about in that differential, does she have anything to support clinically that she could have myocarditis from some other cause? There was really not really a lot there. As we discussed and we tested, or she was tested for many things. Beyond that, could she have had leukemic infiltration? That is something that we've all discussed. Generally, you would imagine that leukemic infiltration would be, again, even more diffuse than what we saw here. And whether or not this is actually drug related, there are just not enough data to fully know in a long, prolonged series whether or not there is some elevation. I think we can derive from some of our other data, particularly with the immune checkpoint story, that we do see at least some significant T2 elevation. We have other data in, we'll say, other TKI treated populations that where we do see some of these signals. Maybe that'll be another conversation 6 months, but at least for now, with gluteronid, that's generally this is generally kind of an N of 1, as Courtney said. We actually did have a second case, a second case of gluteronid associated cardiomyopathy. However, that one was probably a little bit less, you might say, straightforward. Even really, that patient had a baseline borderline EF, I think of 50 or so, and then they got gluteronid, and their EF fell to 35. So, it became another story of what do we do. In that case, the patient really, they had AML. So in the end, I don't think they really made it beyond a year. But so those, I hope those address some of the main points. I think there was also a question about biomarkers. If I heard. This.
Yeah. Can you hear me now?
Yes, much clearer. Yes.
Sorry, I was having some microphone. Oh, the first question was where biomarkers checked and were they elevated?
Yes. I'll go back to that.
Yes. So there was kind of minimal troponin elevation. Go ahead, Courtney, were you saying something?
Yeah, I was just going to bring up where we had the labs. So they actually did check all, like at least a BNP and a troponin on admission, and both of those were, relatively within the normal range. And there was a mild troponin elevation, but up from baseline, and our lab less than 0.11 is negative. And then the BNP was 1500, so clearly abnormal there. And then the other thing with the leukemic infiltration, her ejection fraction did drop over the course of 5 days. And, her white count when she came in was 53. And then after 5 days on the gilteritinib, it's working, it's knocking down to a pancytopenia with a white count of 0.87. So, I would presume or anticipate that if it was all related to this acute leukemia, that we would be seeing the effects when she first presented rather than 5 days later. And we don't see the troponin elevation or the BNP, the clinical heart failure, or the drop in ejection fraction. We were fortunate that they did do a pre-chemotherapy echocardiogram to give us some baseline numbers that showed, a very healthy heart at that point.
There are a couple of other questions in the question box. Jose Alvarez Cardona asked, is FLT3 expressed in the heart? And then a related question, also from Jose, is can you relate the role of FLT3 in an ischemia animal model versus a different setting where ischemia is not the driving force?
For the first question, yes, it is expressed in the heart. It is expressed in cardiomyocytes specifically. They have done the protein and mRNA analysis in isolated cardiomyocytes to show that both the protein and mRNA are present there. As far as how it relates in an ischemia model versus what we're seeing here, that was an activator versus an inhibitor. I don't know what great conclusions we can draw except that it is affecting the myocardium. I think that's a gap on the basic science side of what does an inhibitor do to the heart, and is it related to stress, or can it have an effect in and of itself? And then of course mice are not people, so I think we're kind of seeing this play out in acute leukemias, and trying to just connect the dots from there. But I do think there are big gaps, and I was just trying to show what we do know.
Yeah, no, that's great. And then Hadi Scory asked several questions. I think they're all could probably be summed up as, they found he had seen a similar case to what you had, also developed AFib, and then once heart failure therapy and AFib were given, there was some evidence of CMR myocarditis, and the patient is doing better. How long would you expect to have, or do you have any sense of how long there may be recovery, or whether this is prolonged?
Are you hearing me?
Yes.
Sorry, it was a long question, but I recently had a case that was referred to me because he had acute heart failure decompensation, and I admitted him here in my service here, and he had biventricular failure with severe LVF of 20%, and RV was really moderately to severely dysfunctional too, volume overloaded. Looking back in the history, in January 2020, he was started on gilteritinib, and he was doing fine till he started developing atrial fibrillation flutter in June. His echo in June was normal. Then in September, 40% EF. They related that to high rate atrial fibrillation. They started giving him rate control. And he presented to me late in January this year with this picture. So I stopped gilteritinib. I did a CMR that showed of myocarditis, subendocardial late gadolinium enhancement. I started him medical therapy, but since late January up till now, his EF did not pick up yet. Even I did a cardioversion, and he's now in sinus rhythm for the past 2 months. His EF is still 25%, so he's clinically better. And I saw a great recovery in 5 days in your case. So I was asking, is this toxicity reversible in all patients, or maybe patients who have been on a longer duration on this medication, then the reversibility will be unlikely?
That's a great question, and also thank you for your case and your that you presented. We were fortunate here that this was caught relatively early, and so thus, we were able to intervene relatively early and stop the potentially insulting therapy. Generally, I think the biggest question I would have in my mind that might potentially help us to determine the longevity would be the LGT burden, or at least general fibrosis burden. In some cases, at least from what we've seen with other potential TKI-based therapies, if there's relatively high fibrosis burden or high ECV, that may, at least in some measure, help us better delineate the long-term likelihood of recurrence or recovery. And the other point I would make is it did sound, as you alluded to, that the patient was on prolonged therapy for some time, which then may insinuate that the actual myocardial remodeling may have been relatively extensive by that point, for whatever happened. And as we saw in your case, just correcting the AFib didn't fix the problem. So that again suggests that there's potentially some other process that's ongoing. In your case, how much LGE or ECV or T1 elevation was there?
LGE was reported 5%.
Okay, 5%. And how long exactly was the patient getting gluteronide?
For how long?
Yes.
For 1 year.
Oh, for 1 year.
Yeah.
Yeah.
He was being followed by another cardiologist who related that the drop to his atrial fibrillation flutter. So, and then he started deteriorating over 6 months before he came to me.
No, that's understandable. I think the short answer is, unfortunately, we don't have enough data yet because of the relatively novel nature of this therapy and the number of cases that have been reported or not reported to this point. I think generally, clinically, what I would tell you, based on maybe seeing patients who are on FLT3 or other kind of novel agents, generally what we could derive is that, the patient was on therapy for a prolonged time. The patient had evidence of heart failure for a long time. They probably had a lot of extensive remodeling. We can see that there's a lot of LGE. I would estimate that there was probably a fair amount of subendocardial, diffuse fibrosis as well, and that may better predict. That's what we've seen in the checkpoint story and what we're seeing in maybe some other data. You could say that hopefully will emerge soon, that some of this fibrosis story does help us understand the long-term risk and long-term likelihood of recovery. I see Dr. Campbell is back on.
Thank you.
We can't hear you.
While we're waiting for Courtney, Wonder Masood, did you want to ask a question? Might have time for one more.
Yes, of course. Thank you for nice presentation. I wanted to ask you what is the necessity of CMR? Suppose that your patient is normal and gone under the treated under the TYK inhibitors, and the EF decreased, for example, to 45, 40, and the troponin rise. So I can't understand what is the role of CMR, because, for example, I am from Iran, and in Iran we have some limitation to have a CMR for every. My first question, and the second question, I wanted to know how often should I echo my patient when he or she take TYK inhibitors? Is it the same as Herceptin, for example, for breast cancer? Is it the same as Adriamycin, or no, it is the difference?
Thank you again for that question. The short answer to both questions is there's no data or not enough data. But the kind of more practical question, or answer, would be, there is some question about the potential role and where CMR fits into any algorithmic approach for any anti-cancer therapy. I think personally, if you hear my bias, is that essentially it may help us in the diagnosis and may help us in prognostication. Those are the big two elements where we get some advantage beyond echo. I think as far as the second question, which is duration, again, there's no data, but we would, in this case, we use clinical judgment and based on other therapies and other cases we've seen to argue that maybe a 2 to 3 month approach was reasonable, again, depending upon the intervening therapies, cardiovascular therapies, as well as anti-cancer therapies. And, maybe in a little bit of a challenging resource situation, I think using kind of a relatively serial kind of multi-combinational approach is often really going to be your best bet. In some of those cases, getting a CMR would mostly help you prognosticate, like in the case that the gentleman mentioned before, and then also even in our case as well. Courtney, are you back? Okay, can't hear you. Sorry.
Well,
thank you.
Yeah, no, thank you all so much, and had a lot of great questions and discussion. We appreciate all of your effort. This has been really fantastic, and you know, it's not really a particular toxicity that I've been aware of necessarily, and so again, I learned something new today.
No, thank you all, and thank you, Dan, thank you, Steve, thank you for the opportunity to talk about this case. And we should list as a collaborating institution WashU as well. Right.
So Joe,
great topic. Thank you.
right.
Yeah, can I just make one final comment? First of all, this was awesome. That the incidence of MACE in acute leukemia patients is probably in the 20+% range in the first year. And it's a plea that you guys should all go out to your oncologist colleagues and yes, to see all of these people if you can prior to therapy, if they're electively treated, or when they get admitted to see them in the hospital to just give them as much cardio protection as possible, not only for acute events in the hospital, but follow up afterwards. This was great.
Yeah, no, that's a very important point. You know, if you just apply good cardiovascular protection principles to this population, you're going to have a big impact. That's for sure. All right. Well, thank you all so much, and we look forward to seeing you again sometime. You're welcome anytime. So,
Thank you all.
Thank you. Thank you all. Thank you all. Thank you again.
Goodbye. Thank you.
Thank you.
Thank you.
Thank you.